Okay, so I am Max Melman. I'm the director of the Law Medicine Center here at Case Western Reserve University School of Law. Thank you all for coming to the Elena and Miles Zaremski Law Medicine Forum today. Miles Zaremski is a 1975 graduate of the law school, and he and his wife Elena have endowed this series of lunchtime talks by prominent individuals, and we're very fortunate today to have an extremely prominent individual, Peter Pavarini, who's a partner at Squire Patton Boggs in Columbus and the co-leader of their health care practice group. He focuses his practice on the representation of hospitals and other healthcare providers in a wide range of strategic, regulatory, and transactional matters, especially physician alignment models and the development of clinically integrated provider organizations. Peter's also the immediate past president of the American Health Lawyers Association. He is also an adjunct professor of law here at Case Western, where he teaches in our core health law curriculum. Let me invite you to welcome Peter Pavarini, who will be talking on the rise of retail medicine, legal and policy implications for the American health system. Thank you for coming.
Thank you, Professor Melman. I didn't know I was on the faculty, even in an adjunct capacity. Yesterday, I was graciously given a doctorate by Nancy Pratt, so I thanked her for that. I didn't know I had a doctorate, I guess a Juris Doctorate. So, yeah, well, she may have thought I was a doctor. I'm not, I'm a mister. Happy to be a practicing lawyer. How many of you can remember the day you were born? Probably not too many of you know the date, but you feel like most people, you have no recollection of that. I can assure you that, like everyone, you were born to be a healthcare consumer. Probably the first thing that was purchased on your behalf, particularly if you were born in a hospital, was healthcare services. Think about that. Before you went to your first grocery store or Best Buy or Starbucks, you were purchasing healthcare, or someone was purchasing it on your behalf. What I'd like to use this hour for is to give you a new way of looking at our healthcare system, specifically the American healthcare system, although many things that I will be talking about also apply internationally. We're seeing a lot of the same trends around the world. The title of my presentation is The Rise of Retail Medicine, and some of you may say, well, how does that differ from all other kinds of medicine? And I'll explain that in a second, but let me give you a brief outline of what I'd like to cover. We will start with a definition, and this is pretty much mine. You won't find this in any case book or even really in the literature yet. It's sort of an evolving term. I would like to give you some of the economic and policy considerations that I think are driving this as a trend in healthcare. I want to describe some of the challenges that I see up ahead, and this in turn leads us to a discussion of the law. What does the law of medicine and the law of healthcare have to say about the rise of retail medicine in the United States? And I do want very seriously your questions and your comments. I'll take them along the way if that's appropriate, or we'll reserve some time at the end. But either way, this is not intended to be a one-sided dialogue. So what is retail medicine? Let's start with the proposition that traditional healthcare was not based upon the normal laws of buyers and sellers in the marketplace. There may have been a time where that was true, maybe 100 years ago or so, where there were no third-party payers and there were no government programs. And at that point, medicine probably was like most other retail services. If you had the money and someone had the skill, you paid that person for those skills or those products, and it was a retail exchange. But somewhere along the last 100 years, particularly since World War II, that has changed dramatically. And it's now at least a three-party relationship, and sometimes many more parties are involved in the transaction of selling a healthcare good or service to a consumer. The dramatic growth of retail medicine in just the last few years, and I have a slide that will show you what I mean by that, threatens this paradigm in ways that I don't think we have ever seen before. Not the ACA, colloquially known as Obamacare, not the Medicare program, Medicaid, or really any of the major pieces of legislation will have as much impact on our healthcare system as the rise of retail medicine, in my opinion. And that's because retail medicine gives the patient, as opposed to the physician or the caregiver, the ultimate say in what they do to their bodies, what they put into them, what procedures they have done, and most importantly, how much they're willing to pay for those procedures. We think we do that. If you've ever gone to a physician's office or any other place where you would get services, you think that you're actually paying, but who really is paying? Someone else is paying on your behalf, and maybe you're dealing with what's left over, the balance billing portion of it. The ultimate choice of what you get and who pays for it is often made by someone else who is not under your direct control. Retail medicine comes in a variety of forms, and I think that it's important to understand that because this is somewhat of an amorphous term, I may be leaving some things out, and I may also be including some things that you wouldn't put in retail medicine, but indulge me because this is sort of an inaugural conversation I'm having. I have done this once before at a American Health Lawyers Conference, but this is an evolving topic, and I hope that after I've done this a few times, we'll all come to some agreement of what is retail medicine and what it's not. It is something that does put more importance on convenience and affordability than the traditional system. Because of that, it's a direct threat to many forms of primary care and other kinds of patient-centered care, such as home care, and some of the other things that we do without a doctor's permission. Like if you break an arm, you go to an urgent care center or an emergency room. Those are self-directed forms of care. But most other things that we do for ourselves and our loved ones, we have an intermediary. Someone is making those decisions for us. Retail medicine is a threat to that paradigm. It allows greater localized access, lower and more predictable costs, shorter wait times, and at least in theory, the one-stop shopping experience that we often don't have when we go out in the array of services that the traditional healthcare system provides. Here are a few examples. Walk-in clinics, sometimes called mini clinics. I'm sure you've all seen these cropping up lately. They were first seen inside of retail pharmacy stores. CVS and others will have their mini clinics. Often the same hours as the store itself, which in some cases may be 24/7. Urgent care centers, really not a new concept, have been around at least since the 80s, maybe 90s. It was an opportunity for you to get seen by a physician in an acute urgent setting, but not emergent. It would not be something that was necessarily life-threatening, that you still would have gone to an emergency room. After-hour physicians' offices, doctors who traditionally safeguarded their office hours to be a more normal Monday through Friday 9 to 5 routine are starting to understand that doesn't work with today's lifestyle. We need hours that extend into the evenings and weekends, and many physicians now have those after-hour offices. The relocation of existing practices. If you look around Cleveland, if you look around most major cities, most of the specialists and high-end services that you need are concentrated in the urban core. You're right down the street here from the Cleveland Clinic, so I don't need to tell you that. But that's not where people live, and that's not where their needs are always occurring. So we see a migration of those doctors, often specialists, moving from urban cores to remote locations where they are interfacing with patients in a more accessible fashion. If they can't do it physically, they're doing it virtually. We're using telemedicine to connect those offices with the urban core, the Cleveland clinics, so that if you need a consultation or an interpretation of a diagnostic exam, that you can have the highest level of expertise associated with that, even if you're not where that professional is located. And lastly, workplace clinics, probably the oldest form of retail medicine, started I believe in the early 20th century. My understanding that Gillette, the razor blade company, was the first U.S. company to actually have a company doctor. And if you were making razor blades and got cut on the production line, you could go and see a doctor right there who was employed by the Gillette company. That seems kind of commonplace now, but back then that was pretty radical, that a company would actually see the need to have a physician on the payroll for those situations. Now that's been expanded, and we'll get a little bit more into that in a second. So what are the primary characteristics of these different models? I'm going to go through this quickly because I think most of them are self-evident. The Walkin Clinic, I think accessibility is the number one factor, but close behind is affordability. We know that we're seeing these now even in the Walmart setting, other big box type of stores, which really attract a variety of consumers. People coming for all kinds of needs now associate healthcare as another thing they can do while they're getting their groceries or their clothing or their home goods. They offer extended hours for sure because they're open sometimes 24 hours a day. Most importantly, they're more affordable. And this, most people still don't know that you can probably get that flu shot or that exam that you need for your child's permission to play on a school sport done much cheaper and usually much quicker if you go to one of these walk-in clinics. Is the quality any different? I would argue it's not. For those kinds of routine services, the difference between getting a flu shot at Walmart or at your primary care physician's is essentially the same. We don't see any evidence that there's a trade-off in quality. Because these facilities are staffed differently, generally by nurse practitioners and other advanced practice mid-level professionals as opposed to fully credentialed physicians, they are able to keep their costs below the equivalent in the primary care office. And that is attractive to a lot of patients who are paying for things out of pocket. The urgent care center, as I said, is a step up from that. That's where you've done something a little bit more threatening, not necessarily life-threatening, but you really need attention, probably from someone more than a nurse, although we do have nurse practitioners and physician assistants staffing urgent care centers. But you'd like to have a physician there if a diagnostic exam has to be made that requires a physician's skill. These are typically standalone facilities. They don't have to be associated with a bigger healthcare complex, although you will see some urgent care centers on a hospital campus. Typically, they're in the community where people live. Higher acuity and a physician staff would be two notable features of these facilities. Freestanding emergency departments. Now, this is new. This is something we will see more and more of. There's been an extraordinary number of them planted in our communities just in the last few years. We have a few companies that are doing that on a for-profit basis, and more not-for-profit systems are venturing into the freestanding ER. And what is a freestanding ER? It's basically a hospital without any beds. which means there's no overnight stay. They're going to stabilize you, give you what you need, and then send you on your way. If you need more than that, they have an affiliation with a true hospital that would have all the other services. But if all you need is the services of an emergency department, these facilities are open 24/7. They have the same quality of care. They're staffed by the same kind of ER doctor that you would find in a hospital. And they are becoming the new way to enter into a community. You will see more and more cases where there will be a freestanding ER built in a high-growth area before a hospital. If the freestanding ER is successful, a few years later, they're going to start building a bigger building around it, which will then provide for the overnight stay and for all the other services that a full-service acute care hospital would have. These are staffed very much like hospitals. The same credentials are required of their staff. But again, shorter wait times, easier access. I'm not sure they're any cheaper. They might be a little bit, but they are generally selling their accessibility more than anything else. Other models, the after office hours, I think are pretty self-explanatory. That's just your doctor working longer hours, which hopefully helps you out. Relocated practices, again, look very much like what the traditional ones were. They're just in new locations. And the workplace clinics are becoming more and more prevalent, and they're usually providing a lot more than just urgent care. They're often dealing with wellness, helping the workforce associated with the workplace clinic live healthy lifestyles, helping them with stop smoking, helping them with weight loss, managing chronic conditions, and trying to affect their overall wellness so that they're more productive, happier people. And there's been a lot of evidence that the companies that invest in these workplace clinics are getting a huge return on their investment in terms of lower absenteeism, lower healthcare costs, particularly if they are self-insured and picking up those costs. So these are reasons why employers are looking at this as part of an overall way to manage their healthcare costs for their employees. And I think we're going to see that, maybe not in a law school setting, but we will see it in many of the bigger businesses that can afford to have at least a nurse practitioner on duty. So why is this becoming mainstream, and why should you pay any attention to it? Oh, look at this graph. Those are numbers that are pretty compelling. We went from only 1,400 retail clinics just 3 years ago to now 3,000, more than double in just a short period of time. And I think next year's numbers will be even more impressive. This is probably the leading edge of where healthcare growth is right now. I think we see two other segments that are probably just as active, and that's health information technology, all the forms by which we communicate healthcare data from one person to another. And the third is outsourced services, the things that traditionally were done in a more traditional setting, hospital, institutional setting, that are now being done somewhere else in the world. And that could be like the Nighthawks. Does anyone know what the Nighthawks are? It's a great name. They're a group of American radiologists who decided to move to New Zealand, I assume for the lifestyle. And they also realized it's about a 12-hour difference for what's going on back in U.S. healthcare facilities. So these are the doctors who read X-rays and CT scans and MRIs overnight, except it's daytime for them. So they're able to, using teleradiology, to do interpretations of tests that are being done in the U.S. so that there's almost instantaneous reads back in the U.S. That's an example of outsourcing, and we're going to see more and more of that, using the global interchange of data to be able to manage our healthcare needs and costs in very creative ways. You can stop me at any time. Anyone? Yes?
I have a question regarding this connection with U.S. doctors. they have to be certified, board certified?
Generally speaking, yes. That's a good question. That you see that when doctors leave the U.S., or maybe never were in the U.S., although many of them do have ties here, they may have studied here, they cannot treat a patient who's based in the U.S. unless they are licensed equivalent to the jurisdiction in which the patient resides. Now, I believe that's going to start to bend a little bit. I think that we're going to start seeing there are certain services which we don't really need that level of state regulation on. But today, that's the answer. I think that we're starting to see it with laboratory tests, that everything doesn't have to meet a state standard if it meets a federal standard. I think we could have federal standards on things like teleradiology that would suffice, and that state licensure would be secondary. Yes?
For purposes of the webcasting, we need the questions to be microphone, so
I will.
Wait until then.
Sure. We will do that, and if it's something that's really pressing, I'll repeat your question so that it's on the record. And thank you for pointing that out. Right now, I would say what is fueling retail medicine more than anything else are higher deductibles and copays. And what do I mean by that? Well, if you've heard anything about the insurance exchanges under the ACA and how commercial forms of insurance have changed in just the last few years, you will know that one way to make healthcare more affordable for more people is to bring up the portion that is paid for by the patient. The Cadillac plans, the plans that were first dollar coverage, are becoming less and less common. Most people who have some kind of benefit plan are noticing that they're going to be required to make greater outlay of dollars before the insurance kicks in. Sometimes that outlay is fairly significant, and that is a problem. And that is what you've heard a lot of debate about. You know, is the ACA creating the accessibility to health care that it was intended? And I would argue that in some cases it's not. There are many people who, if they have to spend $5,000 out of pocket before they get any coverage, for them it's like not having insurance. So we are still in that gestational period of broadening the base of people covered by the American healthcare system, still wrestling with the affordability problem. Retail medicine is in response to that. If you can get people taken care of for small amounts of money that they can afford or that they can put on their credit card and they really don't need insurance for, or their insurance just won't cover, there is a demand for that. And I think the greatest growth of retail medicine comes out from people who either can't afford to wait, or even if they can't afford to wait, would prefer to pay for something now, knowing that it's ultimately coming out of their pocket and not the insurance company's pocket. I think that is the reason for this boom, and I think that boom is going to continue for some time. The capital markets see that, and they're investing in retail medicine. There are a number of companies now that are raising capital to build more retail establishments, and if you want to know anything about healthcare, just follow the money. Where the money is coming from and where it's going usually tells you what's really happening in healthcare. Like any other marketplace, competition does kick in, and competition will change the dimensions of this marketplace. We can't have a mini clinic in every supermarket or every drugstore. That does not make sense. We will have consolidation, at least of the brands. But it's just beginning right now. There is still a lot of differentiation in the marketplace, but I would predict over the next 5+ years, you will see consolidation, and the winners and losers will be known. The losers will generally be the inefficient ones that are not as cost effective. They will be the ones that don't have a reputation for quality, and they will close. The ones that will survive will very often become bigger and more dominant, and hopefully will be able to deliver a product on a more predictable basis. The reason why people go to Starbucks and other national brands, even though they'd like to support the local coffee shop, it's predictability. they know what they're getting. At least they think they know what they're getting. Healthcare is no different. If people go to something that's unfamiliar to them, they're going to be a very tough judge of how effective that relationship was. And they'll come back if they thought they were treated fairly and got good service. They won't be back. And consumers are very fickle, and I think this is clearly an area of the economy that we will see consumer preference having a major role. The other sources of capital and interest in retail medicine are really all the usual suspects: hospitals, physicians, retail companies that are really multidisciplinary. They do things beyond healthcare but may have an aligned interest, like pharmacy. Clearly, in foreign countries, you will see that retail medicine is very much a part of the suite of consumer services that conglomerates sell. If you go to Asia, you don't find a lot of unique healthcare companies. They don't have like what we have in this country. You go to an organization which might also be selling clothing and groceries and entertainment and running hotels. It also happens to run hospitals. That's not the way we do it in the United States. But I think we're going to see more and more entry into the marketplace through retail medicine. And you may very well have Marriott and Starwood and Hyatt and others getting into healthcare because, you know, hospitals are sort of like hotels, aren't they? Sort of. And they're becoming more and more like them all the time. And they got their gyms, and why not put a clinic inside of a hotel, right? And wouldn't you have that? You're pretty close, yes.
And I'll speak loud, but repeat the question also. Hotels found out that nursing homes and assisted living and independent living was not. Big hotels found out that nursing homes, independent living, and assisted living were not hotels. They were medical facilities using a medical model.
And so I'm kind of surprised that you said that.
The context in which I said it is that non-U.S. companies don't see that distinction. U.S. companies do, and you don't see U.S. healthcare organizations competing with non-healthcare organizations today for that very reason. Healthcare is much more complex than just putting a roof over people's head and serving 3 square meals a day. I agree with you 100%. The licensure of professionals basically assures that in this country. Not so in some advanced foreign countries where healthcare is much closer to being a consumer product, which doesn't have that same segregation from the rest of the economy. We can go speak to those people about why it's evolved that way, but that's the way it is in many countries. And China is probably the best example. China is a for-profit business. There's virtually no non-profit healthcare sector in China. Now, there may be some government facilities that effectively are non-profit, but most medicine is provided in a for-profit setting in those countries. Why? I don't know. That's just the way they've always been. So I think what we have to say is that this could change the paradigm in the U.S., not necessarily for the better, for that very reason. So that was a very good comment. Healthcare payers are also looking at retail medicine because they want to control their outflow of dollars to pay for claims. If they could get their insured lives into the right setting at a lower cost and get a good care, why not? So you will see some of the largest healthcare insurers are venturing into this area, but very slowly, not as quickly as some of the others. Now, this is something for you policy people who really say, how does this fit what we're trying to do with the Affordable Care Act? We can debate over whether what we have now is working or not, but most people would say since the passage of the ACA, things have changed dramatically. And the one thing that doesn't get enough attention, in my opinion, is that there is, in that 2,000-page piece of legislation, a lot the public doesn't know about. And it often deals with improvement of the delivery system to make it more accountable, to make it more predictable, and only secondarily to make it more cost effective. But I think what we're seeing is that retail medicine may be running against the grain. It may be actually not consistent with the policy behind the ACA, because we want an integrated healthcare system so that people get the care in a continuum as opposed to an episodic fashion. If you buy healthcare on your own, paying it for it out of your pocket, which you can do, but it's not connected with everything else that you do to maintain your health, is that wise? And I think that's the debate that we need to have in the United States in the next few years. I don't think we can stop retail medicine, but I think we can shape it so that it fulfills the promise that it's making, that it's getting closer to the consumer, that it's more patient-driven as opposed to institution-driven. But we want to make sure the quality and the accountability is there that we think our laws are now requiring. As I said, patients are fickle. If they don't think this is going to work, these will become the blockbusters. Anyone remember a Blockbuster? You know, we will have companies that come and go just simply because the marketplace decided that's not what they want. They want to get their health care some other way, and maybe they'll go back to the traditional means if they find that the mini clinic and the urgent care center and the freestanding ED is not really in their best interest. So I think you got to watch what consumers do with this issue. Now I'm going to spend the remaining time on what I think most of you came to hear and saying, well, okay, that's all very fine and well, but tell me, what does the law have to say about health care in the context of a retail medical facility? Not much, surprisingly. This is an area with very little law, almost no case law. If you want to talk about case law, very little case law. We do have statutes and regulations, but 50 different jurisdictions with at least 50 different ways of regulating this. Let's start with corporate practice of medicine. Some of you who have studied health law may know a little bit about this. This is an anachronistic law, dated from the 20s and 30s of the last century. I call it the Sears and Roebuck law. Sears, yes, the Sears that we still consider a department store, hardware store for some, got into providing in-store doctors back in the 30s. And they saw, well, you know, Farmer Jones is coming into town to get seed and some hardware and some new overalls. Maybe Farmer Jones also needs an annual checkup. Well, let's put a doctor in there. They started doing this, and it was actually working. This is a very early form of retail medicine. Well, what did the state medical societies do about that? They were aghast that a corporation like Sears and Roebuck would get into the business of medicine. Felt that compromised the professionalism of the physicians who were working for stores like Sears, and therefore most states, not all, but most states adopted laws prohibiting the corporate practice of medicine. These laws remain on the books in many jurisdictions. Even in Ohio, we still have the remnants of a corporate practice prohibition. However, most of these laws are littered with exceptions and loopholes that allow anyone with a creative mind to get around them. And I don't have the time to show you how we do that, but I will tell you that lawyers are paid a great deal of money to figure out how to avoid these laws so that you are not caught in their snare. However, there are states that do enforce them vigilantly, and in those states it is a much more difficult proposition. I'm thinking of California, I'm thinking of Texas, I'm thinking of New Jersey. In those states, if you hire a physician through a corporation, that corporation better be controlled by physicians. In other words, its shareholders, its board, its officers better also be doctors. And if you can't do that, you have to do some kind of workaround. In other states, there's a little bit more leniency, and I think Ohio is probably in that category. That's a quick corporate practice of medicine summary. How it relates to retail medicine is that most of these establishments, particularly the ones that I just described as growing very rapidly, are corporations. They are not extensions of a physician's practice. Now, the ones that are after our physician offices, they would be the exception. But all the other ones could very well be a group of business people get together and say, let's invest in a mini clinic. And we'll hire some doctors and put the doctors to work and some nurses, and we'll run this mini clinic. In some states, you just can't do that. So we do have a legitimate issue here, partly because those laws were not adopted with retail medicine in mind. They were adopted at a time where these did not exist for the most part. Exceptions might be some in-store clinics that were set up many years ago and have since sunset. Yes.
Are these laws part of the medical boards? Is that what part of the law there? And if so, this revolutionary case that was decided last year by the Supreme Court on antitrust, subjecting state licensing boards that are controlled by the profession to antitrust suits, is that something that is relevant?
Yes, it is relevant. The question is, are these laws enforced by state medical boards? Yes and no. Some states do it through other agencies, but effectively have the same kind of power. State medical board is the most likely place, but typically it's done in conjunction with the Attorney General or Secretary of State if they have a corporations division that has a corporate practice enforcement unit. So that is how it's done. The Supreme Court case you mentioned, like a lot of the antitrust cases that have been brought in the medical profession, going back to the Maricopa County case back in the 80s, whenever the Supreme Court gets a chance to make medicine more competitive and more of a free market as opposed to a closed society where a group of professionals control that service and really prevent competition, you will see pretty much any court, not just the Supreme Court, take a pretty dim view. That being said, if a state legislature adopts one of these laws and goes through all the steps that you need to build one that is enforceable, and I believe the ones that are still enforced in states like New Jersey and Texas have been challenged, and they've been upheld. Do they keep doctors from working for these corporations? In part they do, but they just cause them to be more accountable to their state medical board so that they are still being licensed as professionals as opposed to working for shareholders, and that's the key difference.
We have one additional question over here.
Kind of to piggyback on what we just talked about, do you think it's necessary for these corporate practice of medicine prohibitions to be lifted for healthcare to move forward and for innovation to actually happen? And do you see any other professions similar to healthcare, possibly our own, following the same lead?
I think that debate is going to be with us for some time. We are not yet sure that an unlicensed, unregulated medical profession, legal profession, would be in the best public interest. I think we are, however, pretty certain that experimentation with new forms of professional service delivery are in the consumer's best interest, and we have to be tolerant of some of these new models, but subject them to the same kind of analysis that we did in the past. So that, going back to the example of the mini clinic, if the quality of care you get from a doctor who's employed by a corporation as opposed to a physician group is the same but half the price, and it's more accessible and more people can get the care they need, I don't think you're going to see a majority of Americans wanting the old system. And if the corporate practice of medicine prohibition is in the way, they would want to see that law relaxed, if not eliminated. Most states have done it just through non-enforcement. They leave them on the books to satisfy the state medical lobby, and then they just don't enforce them. And Ohio is very much in that category. There are other states that are even more notorious that you could never get the attention of the state regulators to enforce a corporate practice violation. The next one, and again, in the interest of time, I want to make a little bit more progress here, is the fee splitting prohibition, which is probably, and I want to make sure I'm on the right slide here. Yeah, let me go to this one. Splitting of a fee is just, there's something nefarious about it. Everybody would react the same way, that if you paid a doctor $100 to see you, to do something, and you knew that $30 was going to someone else who made a referral or provided some favor to the doctor, that would bother you. Most people don't like the concept of fee splitting. On the other hand, when you pay your insurance premium for anything, and you know that some percent of it is going to the agent as a commission, you may not like that either, but you think that's normal. And I think where we are right now in healthcare is people haven't really lifted the hood to look underneath the pricing model to see how it really works. And the truth is, doctors and other healthcare professionals are always sharing their revenue stream with other people. They're paying for their malpractice premium, so that some of that money is going to pay for insurance. They're paying their employees and the employees' benefits. They're paying for the facility that they're in. They're paying utilities. So we split fees all the time. The prohibition of these laws, which is usually the kindred law to the corporate practice, you find both laws together in the same part of a state's code, is that if the splitting comes with the expectation of a referral stream or something that would compromise the physician's professional judgment. For instance, let's say if you're in a relationship where someone provides you the facility, the corporation says, we'll give you the clinic, doctor, staff it, equip it, you just have to give us a % of the fees you collect. But if we think you're overusing some of those resources, we can tell you to cut staff, reduce the number of cotton swabs you use and all. In other words, compromise the health care. That would be a problem of fee splitting. Because what we don't want is to get back to, again, a non-physician affecting the quality of care. That's why the fee splitting laws are on the books, and I believe that's why they will stay on the books, because there are occasions where healthcare is compromised. They mostly come up where there are other licensed professionals involved. Example, the orthopedic surgeon who gets a percentage of everything that the physical therapist in a rehab situation gets for the aftercare. You've just had your hip replaced, you're going to need so many weeks of rehab. The physical therapist gets those patients from the orthopedist. Makes sense to send some money back to the doctor who did the surgery, right? Well, no, it's not right. That could be fee splitting depending on how it's set up. It also could violate the anti-kickback and other rules that those of you who have studied healthcare know exist at the federal and state level. So this is another reason why retail medicine has a pretty high hurdle to overcome. They are intrinsically in the business of taking the fee paid by the patient and paying a lot of other people to cover all the services that are delivered in that exchange. I see a hand in the back. Yes, sir. Maybe you could wait for the microphone to come your way.
You were talking about looking under the hood to see the pricing mechanism, which is a nice concept. I had some surgery a couple of years ago, and just on a lark, I asked the doctor, what is this going to cost? Is there some way for me to find out what the breakdown is, who's paying what, because my deductibles had gone up, I was going to be paying more. And all he was able to tell me was, and I thought it was infinitely reasonable for him, he was getting $600 to cut me open, and I thought it was reasonable. Right. So I asked the hospital when I went there for the pre-op testing and all that, what's this going to cost? They said, well, we really don't have anything for that. Now, if we're going to have retail medicine, and the whole idea behind a capitalist system is that you know what the price of things are and you can rationally make your choices. Is there going to be something, some way, some mechanism for an ordinary person? And even though I'm an attorney, you know, I still couldn't find out until you get the bill, you know, until the insurance company, until they say, well, this would have cost you $20,000 if you didn't have insurance, but since your doctor's reasonable, it's $1,200, you know, that kind of thing. If you see where I'm going with that.
I do, and I see that as the single largest criticism of the current traditional system in the United States. If retail medicine is going to prevail, it has to address that issue. This is how they're doing it. They literally do have a fee schedule. If you go into a mini clinic, let's start with something pretty simple. You go into your Walmart, they have the little mini clinic there, or whatever they call care at home or something like that. You ask for their fee schedule, they have a fee schedule. You can say, I need these things, that's the price you pay. In fact, that may be all anyone gets paid. There's may not even accept insurance. So that is its true value. That is much more predictable. Now, I'm not saying that every one of these examples adheres to that model, but that's the model that is compelling. So that, as I said, there are certain things that should be commodities. Getting a flu shot. And we know you can go to just about any pharmacy in the fall of any year and get a flu shot for $15. Go to your primary care doctor before all the insurance claims and everything's are done. It could be $100 that was paid for the same $15 injection. Now, there's not $85 more value in getting that flu shot at your physician's office. Do you all know who Donna Shalala is? Donna was the Secretary of Health and Human Services under Bill Clinton. She was also president of the University of Miami until last year, and now she's with the Clinton Foundation. She told a story, which I thought was remarkable. This was a couple of years ago. She said she told all her employees at the University of Miami Medical School and Hospital, if you need a flu shot, I want you to go to the CVS. I don't want you to come to, we can't afford to use our staff to give you the flu shot. It's much better for us if you go to a retail establishment. That's the Secretary of Health. So I think people get it. The system is still entrenched in the old model where there is this obscurity, and they expect people to trust that the system will work it out and it'll be a fair result. And we know.
Are you saying then that if I go in for surgery, maybe there's no way for them to give me a pricing schedule, or is there some way to work that out? Are there only certain services that a pricing schedule would be reasonable for, or what?
This may be heresy, but I will say you can negotiate any price in our healthcare system, even in the traditional system. If you go to your preferred surgeon at your preferred hospital and you ask to have an anesthesiologist of your choice, you can negotiate those fees in advance if you know how to do it. Now, there are companies that are actually working for the consumer to help them do that. Here's another example, and this is probably the most shocking example, out of California. It was in the news a couple of years ago. CalPERS, the California PERS, basically their state employee system, was paying anywhere from $25,000 to $150,000 for the same surgical procedure. I think it was a knee replacement. Now, why would you have a six-fold variation in the price for the same exact service, no complications and all? So what they decided is that, okay, we'll pick a price sort of in between. I think they picked $35,000 or $40,000, not the lowest price, but something above it, and we'll just put that out to all the orthopedic surgeons, all the orthopedic hospitals in California, and we'll see which ones can do it for $35,000. Anyone want to know what percentage said yes? 100%. 100% said they could do it for $35, even though they had been charging $150. So it seems to me that if you have the law of the marketplace working on your side, now obviously that's a big multi-billion-dollar organization which probably can get its way. How can you, the consumer, have that same kind of clout? You got to speak up. And most of you who are equipped with oratory skills and reasoning, I think should use that if you can, and I would tell my clients that they should be prepared to at least have an answer. If they really don't know, they should say they don't know. But very often they do know what they're going to be paid. and they know what the minimum price is that they can do a procedure for. In the interest of time, because I only have 10 more minutes, I'm going to try to get through some of these other things which I think are really important in terms of where we are going with healthcare. I do want to cover the issue of antitrust because it does come up more and more. And I assume these slides are available for those of you who have greater interest and want to read them. Antitrust is really the nub of this issue. We are in a very, very tumultuous environment right now. You see the mergers and consolidations of hospitals. We see even health plans now becoming bigger and more extensive in how they cover patients basically coast to coast. Where does the consumer fit into all of that? Well, right now, I would say the Federal Trade Commission and the Department of Justice and the state attorney generals have more interest in healthcare than they ever have in at least the 30 years that I've been practicing in this area. I think that's going to continue regardless of changes in administration. I think it's good public policy to make sure we have a highly competitive marketplace to squeeze some of the waste and fraud out, at least through a free market system. Retail medicine turns that paradigm on its head. It is a direct threat to a lot of the traditional providers. They have built their institutions and often spent countless millions building these edifices on the assumption that they will always have their market. And if someone comes in and puts up a freestanding emergency department across the street from the Cleveland Clinic, do you think that's a threat to the Cleveland Clinic's ER? It sure is. And we see that time and time again around the country. Now, as a result, some state legislatures have tried to stop that through increasing the regulation of these new entries into the market. But what we have seen happen more than state regulation are joint ventures. If you can't beat them, join them. So more and more, the companies that typically they come from places like Dallas and Nashville and, hotbeds of healthcare proprietary activity. And they go to the not-for-profit hospitals and say, hey, we're going to put up a freestanding emergency department right in the shopping center where all your patients go. But we'd be happy to share the ownership with you. In fact, we'll guarantee that all the patients that we transfer will go to your hospital. So they are in collusion from the very beginning with the establishment. And a lot of people say, well, how long is that going to last? Well, it's lasted so far. And I know I'm down in Columbus, Polaris, which is our big suburban shopping district north of the city. We have two of these companies going in head-to-head with the local not-for-profit system. And ultimately, I think they're all going to get into joint ventures. So the law of the marketplace, the competition, and the threat of antitrust is shaping how retail medicine actually takes hold in most communities. And in areas outside of the Great Lakes, the Northeast, it's even more so. You will see this out in the western states and in the Sun Belt, much more of a retail medicine environment. Florida has always been a almost pure retail environment. You can't go down any major road in Florida without a billboard advertising some kind of service, and also the malpractice lawyer sign is right next to it. So that's the free market. That's a wild west of free market activity. Ohio is very tame by comparison. All right, a couple of things, and I will take whatever comments or questions you might still have. Let's take a policy question. Clinical integration and population health. These are the new buzzwords in healthcare, and they're directly out of the ACA. They believe that part of what's wrong with healthcare in our system right now, it's not as coordinated as it can be. It's not as accountable as it can be, and the patient sort of gets lost in the maze. And we have built a lot of new structure over the last 5 or 6 years to address this. It's called the Accountable Care Organization. Now,
The jury is still out on whether this is really going to achieve the stated goals, but the federal government and now state governments have put a lot of resources into getting people into organizations of healthcare where all the providers they see are, in fact, coordinated. Do I need that?
Yes.
Okay.
If I'm going to move around, I guess I have to be like a game show host. I believe that this is going to be the greatest challenge to retail medicine. If retail medicine wants to be the thorn in everybody's side, kind of irking the system to get more efficient, it's going to have to play by these new rules. It's going to have to be part of a coordinated system of care for your mini clinic or your urgent care center or your freestanding emergency department or your workplace clinic to be connected in some way. And the way that's going to happen is through information exchange. I think without a seamless information network where wherever you go, your healthcare records are available to you and your caregiver in a seamless fashion, retail medicine will become an island and it will be disconnected from the rest of our system as it reforms. Can it survive in today's payment environment? And there's some question about that. I've been saying that people are willing to pay out of pocket for things they absolutely need that are relatively affordable. But if deductibles continue to go up and co-payments, are you going to go to one of these facilities if it means you're not using your insurance? I think not. Most people will go to where their insurance covers them. They won't go to the retail establishments. As a result, retail providers have to get into the insurance networks, the payment networks, to be viable. Is it indicative of a larger trend? I would say it is. It's do-it-yourself healthcare. You've all heard about wearable technologies. Maybe some of you have them on right now, counting how many steps you took today and how many calories you consumed, right? Well, if we do that across the board and we become our primary caregiver, retail medicine has to be in partnership with the patient to be able to manage that information and the decision-making that goes with it. Right now, I don't think it does. Public policy has to become much clearer than it is. Right now, it's confused. There are a lot of things in the law, like the corporate practice of medicine and other laws like that, which are contradictory to retail medicine. That needs to be reformed. Unfortunately, the law is a lagging indicator. If you look at our laws, all laws, they really don't reflect what's happening in the marketplace today. So our lawmakers, our regulators need to understand this trend and to make it a part of the new American health system. And with that, I will take a question or two in the moments we have left.
Mr. Pavarini, I'm wondering whether you foresee the possibility of these retail places having, thank you, whether you foresee the retail merchants encompassing social workers, addiction providers for the medical care that's necessary, psychologists, and drop-in centers for those with mental health issues. And the reason I ask is I sit on a board where we spend millions of dollars to the different nonprofits and providing services for the community out of tax dollars. And if there are these type of facilities available in the future, this will impact the Adams boards of the state of Ohio in how we fund the system. I appreciate a comment on that.
That's a wonderful topic. The whole issue of mental health, behavioral health parity with the other forms of health care, we're still in the infancy. We have laws that say that there should be parity, but this is another example of where there isn't. I found no examples of urgent care centers, mini clinics, or anything that are doing behavioral health care right now. Why not? Probably because they just don't know how to commercialize it. As soon as they can figure out that there's a market for those services, there's be no reason in the world not to have a counseling component at any one of these. Right now, I think we're doing the meat and potatoes, literally, the really simple stuff. the sore throat, the bruised arm. When we start getting into things that really don't need to be done in a more established environment, but could be done, and I think a lot of counseling services can be done in an outpatient type of setting, we really need to do that. And the parity laws should make, if you have coverage, it should work as well at a clinic as it does at a counseling center.
One short question, maybe?
Yes.
A short question? And then we'll stop.
You have primarily discussed the retail medicine in the bricks and mortar. It has been my experience that the next frontier, or at our doorsteps now, is the telemedicine primary care, in which you're doing actual diagnosis and prescription drug scripts and over Skyping. My generation, the older generation may not accept it now, but the law students of today, it's nothing to them. Do you see any legal issues, because these doctors may be outside of Ohio, liability if the group plan had lowered the deductibles and co-pays to encourage their participants to be involved with this?
If I had Professor Melman's job, that's what I'd be studying right now. Because I agree, the whole issue, I call it virtual medicine. About 10 years ago, I was hired by a client in North Carolina to help bring primary care to the very rural mountainous areas in the state, and there just were no doctors. And they wanted to do it with online virtual exams where the patients could provide as much in a long distance setting, and then if they needed to come in, then they would. That was just radical. There was no state laws, and even within the state, the state medical practice laws would prohibit most of that. They are starting to liberalize those laws. One by one, you're starting to see some of those barriers fall. They are also falling with what advanced practice nurses can do, what mid-levels can do, what even alternative healthcare providers can and should do. And as those reform, you will see that retail medicine will encompass some of these other varieties of healthcare. As I said, we're starting with a very narrow sliver only because it's easy to commercialize. If you could turn it into a business, it's likely to be built. If it's still vague, I think you're going to find very few people willing to put up the money and the time to build these organizations. But that is a very fascinating leading edge topic, and I do believe it goes beyond our boundaries. I mean, we are looking at this as a global issue now throughout the world.
So thank you very much, Peter. Please join me in thanking Peter for an excellent presentation.
Thank you.
We will, can we post the slides on the Law Medicine website? Okay, so there, as you could tell, there was a lot of material that Peter didn't get a chance to talk about, but those slides will be posted, at least if that's all right with you, for a while. Yeah, one other thing, Peter mentioned wellness programs as a sort of an employer, sort of the new doctor in the in the factory. Next Friday, April 15th, Tax Day, we're having a conference on wellness programs. It's entitled, "Are They Hazardous to Your Well-Being?" And as you can tell from the title, this is not going to be a sort of a vanilla endorsement of wellness programs. It's going to be quite a critical look. And one of the things we'll be looking at is Peter right that they actually save money and possibly even improve health outcomes, so health status. So please join us. That's also
Glad there's
free.
a good debate on that.
And we will do that next Friday.
Are they fighting this tooth and nail, or are they